Okay, so welcome this really interesting session, Building Bridges, Pathways, and Opportunities in Global Health. And so the goal today was to hear the experience of three outstanding physicians, researchers at UBC here on campus who've had an interesting experience getting involved in global health. And some of you might wonder, how do I get involved in global health? So the purpose of this session is to ask these three experts all the questions you have if you're ever thinking about doing some global health work in the future. So we're going to discover how these clinicians and researchers got into their work, their global health work, and to try to create broad impact and gain a little bit of insight in their journey. And then as you can notice, well, you'll find out we have people at very different career stage, and I'm going to start with you, Harpreet, and then Shahrzad and Mike. And unfortunately, Fiona is in the plane. She couldn't make it today, but I'll just start by briefly introducing our three panelists and then give them a little bit of time to present themselves and the research and more their work in more detail. So first of all, I welcome Harpreet Chhina, who's a research associate in the Department of Orthopedics. And she's originally from India and has had tons of experience in research, as you will see, and most recently doing work to improve the quality of life for children who live with limb deformities. It sounds, when you think about this, an anomaly like this can impact every aspect of your life. And so it's really important work she's going to tell us more about. And then we have Shahrzad Joharifard, who's a pediatric surgeon, staff surgeon here at BC Children's Hospital. Dr. Joharifard has tons of experience. I was very humble reading your, actually I worked with her for a couple of years, but didn't know all this extensive clinical research work that she's done in Africa and building this interesting program, surgery training program called Vital Surgery. There's even a video on YouTube you can look at, very impressive work that she's doing, and perhaps we could send the link for those of you who have an interest in learning more about that. And then we have Mike Kobor. Professor Kobor is an outstanding senior investigator here at UBC and BC Children's Hospital Research Institute. And he has an extensive network of collaborators all across the world studying different populations to understand how epigenetic changes affect the life across the whole continuum from before birth to an older, to elderly age. So welcome to you all three. And so Harpreet, I'm going to ask you to, I think people have slides. I'm going to ask you to briefly introduce yourself and then talk about your journey. And then we'll go from one another, and feel free to interrupt if you have questions. And at the end, we'll come back and discuss some of these aspects in more details. So you want me to, do you want to stand here? That's
yeah.
fine. Yeah. Okay.
Just trying to find my slides.
Yeah, so forward.
Sorry, Stephanie, do you have them here? I think this is my.
Yeah, it's just.
Oh, okay. Okay, thank you for the kind introduction, and good afternoon, everyone. So when I met with Stephanie and the organizers of this panel, they suggested that maybe I could start with telling people about my journey, about my story. So I'm going to just start with telling my story. So this is me on my recent visit to my hometown in India in 2024. I was born and brought up in India, in the northern part, in the province of Punjab, in a very small town. And that's where I grew up and had all of my education. And then I went on to do a master's degree in human anatomy from one of the government medical colleges in India. And that's also when I immigrated to Canada in 2005. Then I ended up doing my second master's degree here from UBC in the Department of Experimental Medicine. And then in 2021, I did a PhD again from the Department of Experimental Medicine, which is where I actually stepped into global health research, built a lot of my connections, and also did some mixed methods research at that time. So in terms of my employment history, I started in the Department of Orthopedics at PC Children's in 2006 as a volunteer research assistant, and then carried on in different roles in research, continuing on to my current role and position as a research associate in the Department of Orthopedics at the University of British Columbia. So yes, I have been in orthopedics for almost 19 years, a long time. So my research interests are particularly around outcomes-based research. I am specifically interested in quality of life and patient-reported outcome measures, how to develop and validate them, and also the implementation of outcome measures in clinical practice. A lot of my PhD work, or I would say all of my PhD work, was focused around the measurement of quality of life in children with lower limb differences, not just here at BC Children's Hospitals, but at several of the collaborating centers, and some of them are shown on the map here. So during my PhD, I worked together with patients, their families, clinicians, and other healthcare professionals from 16 centers from 7 different countries around the world. So that was during the development and validation of this tool, which is called LimbQ Kids. And it is internationally applicable. And we just finished the international validation earlier this year. And during this time, I had a really rich experience learning from several different patients from different ethnic backgrounds, different clinical teams. And I was also involved in translating and culturally adapting this new outcome measure into several different languages. So to date, I think we have about 8 languages where we have done full translation. Some of them are published and they're ready to be used, and about 3 or 4 that I am in the process of still translating and culturally adapting, again, working very closely with the clinicians and researchers from all of those centers. My other area of interest lies around developing international registries for some of the rare orthopedic conditions that fall under the umbrella of limb differences. There are about 12 conditions that loosely come under this umbrella. We have just launched our international registry for osteogenesis imperfecta in 2024. And this year, we are working on an international registry for musculoskeletal infections, specifically focusing on orthopedic outcomes. And for the development of these registries, we are again working with clinicians and researchers from about 23 different centers around the world. So I am the scientific lead for the International Limb Difference Registry, along with Dr. Tony Kobor from Orthopedics. And it has been a really rewarding experience so far, trying to build these registries and continuing to build these ones. My connection with global health, as you can imagine, I'm an immigrant from India a long time ago. So I think I have a deep understanding of how the healthcare systems work there, and also in many other similar low and middle income countries. And while I know that these countries still grapple with providing basic healthcare to their citizens, but still those clinicians, those researchers, and those teams still have many valuable lessons that we could learn from them and bring it back to our systems here. I know the tool that I have developed, maybe some of those countries are not ready to use those because they are still struggling to provide basic healthcare. But I think just creating awareness and starting to have that dialogue, I think goes a long way. And I have seen that some of those sites are actually starting to think that these differences not just impact their physical function, it is their overall life of these kids, their psychological health, their emotional health, it is impacted. So I think even a little bit of difference, I think it goes a long way. And also, I think the opportunity that comes with the rich and diverse data that we could get from international collaborations, that's just unparalleled. We can't do much with the data from our little department here or from our little site or from just one country. With this international collaborative model, I think the data becomes really rich and we could do a lot more and we could answer many more important research questions if we can try to use that approach. So when I first started working in this field and started my qualitative research interviews in India, I very quickly realized how rich the data is, and which further strengthened my commitment to continue this approach. It shaped my career trajectory, and also I keep working towards that goal of more inclusive approach. So in this picture on the right-hand side is PGI-MER, where I did a lot of my research work. It is one of the premier tertiary care hospitals in India. It provides care to about 8 or 9 provinces in India. And on the left-hand side is me while I was doing some qualitative research work a few years ago and interviewing one of the patients there. The impact of this global health research on me personally has been huge. It has been very gratifying for me at multiple levels. It has enhanced my knowledge, my skills, and provided me with a lot of experience in cross-cultural communication and interdisciplinary collaboration. It has allowed me to make connections with the leaders in the field. I have the opportunity to write papers with people from different teams, from different ethnic backgrounds and different experiences. It has also strengthened my understanding of global healthcare system way more than I thought I knew. I could understand their differences, their inequities better by working alongside with them. And the impact of this global health research on our research program here at BC Children's has also been very valuable. It has in fact allowed us to build many new bridges. We have strengthened our existing collaborations, made several new collaborations. We also had the opportunity to learn from teams from different parts of the world. This has created training opportunities for not just our students here at BC Children's, but also at all of those collaborating centers across the world. There has been an amazing cross-pollination of ideas, which has been really exciting and which is something that keeps me and I think my team going. It has also allowed us to create awareness for limb differences in children, especially in the underserved regions where I think sometimes those differences could be overlooked. And lastly, I think this model of collaboration that we have created, it's very simple, but I think this is something other people can also adopt from us. In terms of the challenges, I can talk about many, but I think these are the key ones. Of course, funding and resource limitations, always at the top of the list when you're trying to do multi-center research, and especially when you're trying to involve partners from low and middle income countries. I think we were fortunate to have some big grants down the road, but still, we still struggle, especially when we want to provide support to those centers where they don't have established research infrastructure, they don't have basic research training. So I think more funding is always better. Ethics and getting data transfer agreements is always challenging, and it just adds another layer of complexity, especially when you are doing multi-center research. And I sometimes feel it just takes the fun out of the exciting work you want to do. It takes years to sometimes get those approvals. And there are also infrastructure and training gaps that you could find when you're working with different teams, especially from underserved regions, which could sometimes hinder your work or delay your progress, or you might feel discouraged. But I also think this calls for even more push to continue doing global health research or to advocate for it and just keep pushing to get more resources towards it. And thank you for listening.
Okay, thank you, Harpreet. That was really interesting. So you, I think a lot of what I forgot to do, and if people don't mind, I go back, is to try to sense the where people are in their career stage in the audience. So if you could just quickly access this QR code and answer the simple Slido, and that will be relevant because I think a lot of people from the pre-registration list we saw are exactly like you, Harpreet, people at an early stage in their career thinking about how, maybe thinking about how they're going to get involved in global health research. And what I find interesting is in your story also is that you come from India, and so it's a little bit different than most people here trying to think about how to get involved in research in those places. But you came from India, and here you told us a little bit about how you connected to orthopedics. But if you wouldn't mind sharing more about how this went for you. But before you do that, let's just see what the answer of the Slido is. How do I put it up there, Stephanie? We have to swap technologies. Okay.
I should have pulled it up.
Okay, well, all right. I guess it's better if people see. All right. We got 40% staff, and actually it is a bit more senior than I expected. But maybe even for staff and people more advanced in their career, I wonder if you could expand a little bit on how was it for you when you came to Canada, how you identified a research environment where your baggage could have the most impact in the field.
Okay, I think I did touched on some of those points in my presentation as well. I think a lot of it is because I really wanted to do it. I was constantly seeking, okay, who could help me build those connections, and where can I go to find those sources? And also I was very, very fortunate and very privileged to work with an amazing team in orthopedics who provided me those opportunities. So I think it's a combination of I think your own commitment to what you want to do and to keep trying. This is something that has worked for me, to just keep trying. And again, my team at Orthopedics have supported me in doing so. So I was able to find these resources, but also to meet people who are in the field, make connections and seek help and seek guidance from the people who have done this before. And never afraid to ask for help. That's something I think I learned after first few years. And I thought, okay, I don't want to go ask for help. I don't want to ask people for funding or for support or anything. But I think most people are more than happy to help and provide guidance. So if there are any trainees, I would say, don't hesitate to ask for help.
Did you know you wanted to do global health research at the time? I guess I'm thinking here people know a little. Probably people know a little bit about the Institute for Global Health, but having a core group of staff and researchers that are involved in this area was, I imagine, a great interest and help to attract you to BC.
I mean, in fact, I wasn't aware of the Institute of Global Health for a very long time, that it existed in the hospital here. And again, I don't know, maybe a lot of people are already aware, but I wasn't aware. And I think I became aware very recently, and I started looking at some of the work. And again, I wasn't involved with the Institute up until now my colleague, Emily Schaefer, who suggested, probably recommended my name to present here and stay connected. So I think maybe that there's more the Institute for Global Health can do to create awareness for those who want to do this kind of work, to say, okay, we are here if you want to get involved. and try to reach out to people. And maybe there might be people who don't want to seek out help, as I was when I first came here.
Yeah, thank you. And the other question I had for you is, if you wouldn't mind speaking, you mentioned in your presentation, you talk about implementing research in those places, but they may not be ready for it. And if you could speak to the structural systems challenges with doing research, that how we conceive it here to doing it in a low and middle income country, or and how different it could be, and what are the things that people need to be aware of in engaging in global health?
I think that's a very good question. And in fact, I could relate to my recent conversation with one of the clinicians in India who was involved in developing this outcome measure with me. And he said, oh, I know I can't right away start using this tool, but now I know I have to ask these kids, how do they feel about how they look? I know I need to just ask them, oh, how are you doing at school more often? Or are you sad about your leg? Because initially he's like, being an orthopedic surgeon, I was so focused on physical function. And the same thing here within our department, I know the orthopedic surgeons just focus more on physical function. So just creating awareness that it could be just a simple question to these kids. How are you feeling? How do you feel about your leg? While the teams here, I know in our department, we could refer these kids for social services, for psychological health. They could go to child life. There are a lot of different things we could do. If they use this tool, they identify these challenges for these kids. And I know in India and other parts of the world, they might not have those services. So implementing this would be different. Maybe some of the centers in the big cities could try to implement, but it could just start with a very simple question to these kids: how are you feeling? So I think we can't do exactly the same thing maybe right away, but it could still make a huge difference to those kids and improving their quality of life.
Okay, thank you. Harpreet, I'm going to move on to our next speaker. Thank you for your sharing your experience. And I wanted to read you a little bit of Dr. Joharifard's bio, though I'm sure she's going to introduce herself. But Dr. Joharifard completed her MD at Duke University and then an MPH at Harvard School of Public Health, and then a residency at UBC in general surgery and pediatric surgery training at Saint Justine in Montreal. But what I find particularly impressive is all the work she's done building a surgical training program in Sub-Saharan Africa, Congo, South Sudan, Ethiopia, and a long list of places. But these are countries, if you think about it, that are very close to conflicts, wars, post-conflict. So the challenges of working in these areas are huge. And so she's she spent 3 months of the year working on the field with Doctors Without Border, where she operates on patients of all ages. So you can imagine the breadth of competencies and mental strength it takes to accomplish these things. So Shahrzad, please tell us a little bit more about this.
Thanks, Pascal. I don't ever want to be the center of attention, but I see poor Stephanie struggling. It seems like if you're over there and I'm over here, it will only focus on you. And that's fine. I don't need to be in picture, but I feel for you, Stephanie. And it might just focus on an empty screen. No, I don't have any slides. Okay, it looks like it just wants to be an empty screen. Do you want me to go stand there, or do you want to?
Might be better. I'm sorry.
Okay.
I tried to set it beforehand and it's not
It
doing what
doesn't want to cooperate, hey? It's just being AI.
Stand here,
Okay.
Shahrzad.
I'll just stand there.
I'll stay facing.
Okay, the first thing you'll notice is I look very different than the picture that I have up there, so I need to get a different picture. I'm naturally blonde. I'm going to be really, really brief because I think the best thing about these sorts of panels are the opportunity for you guys to ask questions and for us to interact. But I think the thing that I can maybe touch on, which would be relevant for this audience that is a non-surgical audience, is really the importance of partnership. As Pascal mentioned, the majority of my work is in conflict and post-conflict areas of sub-Saharan Africa, areas that we call medical deserts, or more specifically surgical deserts. That's really where there are no surgical providers in the entire country in some situations. So for example, where we currently work in South Sudan and Central African Republic, there are no pediatric surgeons, zero, and there are a handful of adult surgeons who will do the breadths of surgical care. So what we do with our vital surgery training program is to train non-surgeons to do the task of what general surgeons do here in this country, or pediatric surgeons do. But really, what has allowed us to get into countries like South Sudan, Central African Republic, Democratic Republic of the Congo, is a partnership with Médecins Sans Frontières, or Doctors Without Borders, because that's one of the very few organizations that's working in areas that are affected by conflict. So without that partnership, we as UBC clinicians and researchers really would have no access. So obviously working with a partner organization brings a lot of challenges, especially an organization like MSF, which is a bit of a behemoth. For those of you who don't know, it's got a franchise model. So there are different operational centers that work, sometimes multiple operational centers in a certain country. So for example, South Sudan, there are 5 different operational centers that work. And so if you are working in different locations in South Sudan, you might be working with different bureaucracy from different operational centers within that country. So it brings a lot of headache, but also brings a lot of opportunity. So one of the ways that, for example, we've solved the problem of not having any trained surgeons in a country where we're trying to train GP surgeons is to use MSF surgeons as trainers. So what that means is that we have MSF surgeons from all over the world who are going to do brief assignments in countries like South Sudan, Central African Republic, and then they act as the trainers for our GPs. So that's a huge opportunity where otherwise you wouldn't have the opportunity to train. So certainly would be happy to answer questions about what that partnership is like, what it's been like to build that partnership, the headaches that go along with that. We're already referred to the questions of IRB, which involve, IRB from UBC, then it involves IRB from MSF, sometimes from multiple MSF centers, and then IRB in country. Sometimes in situations where IRB doesn't really exist, but you're kind of going through the motions. And of course, tackling the bureaucracy of an NGO that's not research focused, but is open to research. So really having to always focus on giving a clinical lens or importance to bringing research questions to MSF leadership in order to get research through the pathway. So I'm going to stop there because, again, I think it's most interesting for us to have back and forth discussion, but that's just a few little snippets of what might be useful for talk about, and I'm happy to answer any questions from the audience.
Can you still hear us?
Everybody hear me? On Zoom or? Okay.
Yes. Okay. All right. I just keep it for now. I have this one. Okay, so our third panelist is Professor Mike Kobor. Dr. Kobor has been around for a while. He has tons of contribution, both in our community, but internationally in the area of epigenetic. And I will hear about all the partnerships that he's created over the years. Yeah, I'm going to stand out of the way so you can get this focus on.
What do you have to do here?
Maybe make it full screen.
Oh.
Switch it to this one. That's the one.
Oh, you guys do that. I'm a market person, so. Stephanie, shall I start? Or? So, yeah, great to be here. Thanks, Pascal and the Institute for inviting me. I think I'm going to present a very different perspective than these two wonderful speakers before me. In that I think I represent the basic an aspect and opportunity for really basic biomedical sciences to get involved. As you probably can hear, I have a fairly thick accent. I was born and grew up in southern Germany in the Black Forest area. Went to undergrad at the University of Heidelberg to study molecular biology. Then decided it's time to go across the pond and went to Toronto to do a PhD in molecular genetics. And then after that, went further west to the University of California at Berkeley, where I did a postdoc and first got involved in what then was a very new field of epigenetics. And as Pascal said, I've been around. I think I came here in almost 20 years ago, May 2005, to UBC and the BC Jones Hospital and the Department of Medical Genetics, where I've been sort of making my way through the ranks eventually. And so what I'd like to do today is just very briefly touch upon how we really, as Pascal said, got involved in many, many different global health projects, even though I myself have zero lived experience in the global health space. And really the secret is this first word here is this epigenetics, which we happen to do, I think, fairly well. And so the way, of course, our textbooks written about what epigenetics is, we very simply look at epigenetics as the interface of nature and nurture. So the DNA that we were given by our parents at conception, and so the green fertile grounds of our families, of our environments, of our communities. And we really look at this in the context of providing the best healthy starts for our children, preventing disease, and increasingly really putting a life course and a lifespan lens through all of this. We're also starting to get involved in looking at this through integrating the genetics to all of this, but today I'm really going to focus for the global health. We've really so far done the epigenetics and environment axis. And the way we basically operate is the idea that environments and exposures at a certain point can get under the skin and they can potentially stick with us through the rest of our life. And so up on top, you see a review that my former postdoc, Meg Jones, wrote when she was in the lab. She's now a professor at the University of Manitoba in Winnipeg. But basically, the idea is that there are certain sensitive periods, and we have historically focused on those early in life, so preconception and the first few years, and where the physiology of the human body is very sensitive to listening to experiences and exposures and environments, good or bad. And you probably know that your genome is more or less, not entirely, but more or less set with what you get from your mom, from your dad. There's some changes in the immune system and such. But what turns out that the epigenome is actually changing as we go through life. And what Meg here has conceptualized is the idea that if there is an exposure during the this early life sensitive period, the epigenome's trajectory might actually be altered. And in some cases might be altered permanently, where you then see this red line going all the way through life and eventually ending up in a higher risk for all kinds of diseases. And primarily, this has been shown for chronic diseases, asthma, allergies, heart disease, and all kinds of stuff. And so, however, if the same exposure happened to be outside of this sensitive period, it might have less of an impact on the trajectory of your epigenome. And this really has been, I want to give credit here to, I don't know how many of you still remember him, but the late Clyde Hertzman, who was the founder of the Human Early Learning Partnership at UBC and really a force of nature when it came to understanding health in a sort of more social context. And he in the 90s came up with this idea of biological embedding of early life experiences and how this affects health and adulthood. So really putting a life course lens to things. And we've been doing this ever since 2007, 2008 here in our laboratory at BC Children's. And when Stephanie sent me this questionnaire, I just could not remember how we first got involved in global health. it was because somebody actually that I knew said, hey, I have this cohort in Cebu in the Philippines. Would you be interested in doing epigenetics with us? And so that's how it started. And where we're now, and this is a snapshot on this sort of map, we have many, many collaborations, many in Africa, 2 in Malawi, I'll talk a bit more, Costa Rica, Asia. And in all cases, those are actually with partners, with collaborators at other institutions, most often in the United States, but also some in Canada and others around the world. And we have been very lucky, and this already came up in, I think, the first and second is that we, due to the strength of our partnerships, we're able to get funding for all of these studies from NIH and CHR and so forth. Most recently also from Wellcome Leap. And then I was lucky enough to also have some funding from my previous BC leadership chair that I could help to sort of start some of the projects. And it's been really a fantastic journey. And if you look at this sort of timeline here, so we started in sort of 2012, 2014, we got the first grant in 2014 with Tom McDade, who was at Northwestern University, and then sort of moved on. It's actually, I don't know how many of you know the Drakenstein cohort in Cape Town, other than Pascal? Well, you don't count. So this is a cohort, if I understand correctly, was actually started in Cape Town or outside of Cape Town by researchers, primarily David Speard and others from BC Children's Pediatrics. I didn't know that when we got involved in this, but now we're involved in an NIH grant with Karis and Conan at Harvard to start this. We've been working with folks like David Rekopf at Stanford to look at Costa Rica. I already mentioned the Cebu, the Philippine study. They've been involved very intimately in aspect of epigenetics, where we have 2 or 3 different grants. And then sort of it spiraled, right? So then somebody said, oh, I hear you're doing epigenetics in global, you kind of, are you interested? And so, there's this guy, Zach Zimmer, who's at Mount Allison University. He's looking at war survivors in Vietnam. And so we got a grant with him. And then, somebody's postdoc then moved on, like Lee Gertner was a postdoc with Tom McDade and Chris Kusawa, who worked with them, moved to Notre Dame, got his own grant and continued projects and so forth. And then, I don't go to many meetings, but occasionally I talk a lot to people. And then I was at Sick Kids at a Global Health Symposium, and somebody approached me, oh, you're doing epigenetics. Are you interested in working with us in Bangladesh with a randomized control trial? Okay, sure, why not? So, so forth. And so, I think most recently we have been gotten in 2 big NIH projects in Malawi. I understand some people here in the group work in Malawi, where we basically look at epigenetics and through the life course lens. And so, yeah, you see it's been a really kind of fascinating journey. And another project that I'm really excited about is with the Tutsis in Rwanda, the refugees there, and how that, again, all under the umbrella, how do these experiences, whether they're early in life, whether they're later in life, whether they're traumatic, like the war experience and such, or how do they get under the skin to affect health and behavior across the lifespan. And really the secret for all of this, as I mentioned, for us to be involved, is not that we're global health experts, but that we're actually epigenetics experts. And it just so happened that epigenetics became very popular. And maybe we have a small part in making it popular. And really that we have a wonderful crew from the wet lab to the analysis team, to the students and the trainees that manage to engage with our various partners at the different universities and do what I think is the most high quality work in that space in the world. And so, yeah, it has been a fantastic journey. I think we already heard about some of the challenges. I think it's interesting, all the same. Like if you meet my research manager, Tanya Erb, getting the samples out of Bangladesh took something like 2 years for a variety of reasons, including finding the right courier and all that. But, I'm a glass half full kind of guy. So despite all these challenges, I think just the collaboration and the interdisciplinary research that you can do in this global space is fascinating. And most importantly, also for us, something that we have been engaged in, and increasingly so, is the capacity building So we don't have primary partners like many of you do in these places, but through our collaborators in the US or Canada, we reach out, and now we, so for example, we had already visitors from Cape Town University coming to our lab to, from hands-on, learn how we analyze this data, how they're created. We have visitors from Aga Khan University in Pakistan, and from the Malawi cohort, we have visitors scheduled to come later this year. And so I think for me, really, we try to sort of utilize a sort of global society to cell paradigm to model what we think is really important, the social determinants of health across multiple systems, including the global space, and the life course to mechanistically understand and transition and translate impactful health outcomes. And having this contrasting, so for example, I just give you one example with the work in the Cebu in the Philippines, we had already here shown many times that early life poverty gets under your skin, alters your epigenetic trajectory. Then the question is that the same if you look at in Cebu, what are the similarities and what are the differences? And of course, as you might have heard, there's this new tool that everybody gets all excited about, the epigenetic clocks, which is basically the idea that your epigenetic age might be different than your biological age. How does it all sort of fit into this global space? And if you have any question, I have actually a much more qualified person with me. That's Hannah Ruth Engelbrecht sits here, who's a wonderful PhD student in the lab and actually works on 3 of those global cohorts and hails from South Africa herself. Great, thank you.
I guess we'll go through some questions. Where do you want us to stand, Stephanie? We all go back over there. You all go back
Okay,
there?
sure.
So I mute this one?
Yeah.
Questions?
Your microphone.
Spoken. Perfect. Thank you so much. Very informative panel.
Introducing yourself quickly.
Of course, I'm Ali. I'm research associate in pediatric leukemia lab in Dr. Gregor Reed lab at BC Children's Hospital Research Institute. Actually, the question I have is when you do this multi-center or international collaboration, funding is something that in first talk we had as a challenge too. So how do you deal with spending the cost? For example, if you get the funding from CIHR, are you allowed to cover the cost that you have in other countries? Or when you have collaborators from other countries, how do you plan for it? You start with some sort of negotiation saying that like 50-50, 20-80. What is the rule of thumb for managing the funding for collaborations? Thank you.
To start, Mike.
Oh, okay. Well, so for us, of course, it's very molecular, and it's a great question. Generally speaking, we actually spend 90% of the money here and get paid to do so from our partners, because our main expense is the expendables for these epigenetic assays we do and the people that run them. It's a little bit trickier for us when we want to bring somebody in from somewhere else, because then sometimes that who's paying for, we know all the Vancouver prices, housing and stuff, who's paying for that, but it's all, for us, it's not a big problem.
It obviously depends on the granting agency. Sometimes it can be quite challenging to pay for salaries in other countries, depending on the granting agency. A lot of granting agencies nowadays are trying to make sure that a lot of the money that if you're doing global health research, that a lot of the money is being spent in the country with which your partnership is occurring, which makes very good sense. So I think it's getting a little bit easier from my perspective, doing clinical and clinical education research. It's becoming easier to be able to spend money there rather than spend money here. And then, of course, when you're in a partnership with another organization, in my case, an NGO, it becomes really important to have that established up front. So MOUs, Memorandum of Understanding, and the many, many lawyers that must get involved in creating those MOUs are critically important to make sure that there aren't any unhappy parties as the money starts to get spent.
So first of all, there's no rule of thumb, I think. It could work in many different ways, as just explained. I think in my experience, I did have a CHR grant for one of my projects, but if you lay it out in the budget upfront that this is where you are going to spend your money and it gets approved, then I don't think there's any big hurdles other than getting those data transfer agreements and writing that transfer of funds within it. Sometimes, again, delays your work. Like an example from my project is we started work already and our partners were really committed to do that work. And the money came in afterwards. So by the time we got the funding, half of our work was already done. So it still took us about 1.5 years or almost 2 years to give that money to those centers because of those legal contracts and going through the paperwork. But we were able to eventually do it. So if you have the money, you write it into your budget that this is where the money is going to go. It's approved. I think it shouldn't be very challenging other than the delays.
I'm going to say one thing that's going to be unpopular with UBC, but it is true. Recently, if you're a clinical researcher, which may or may not be your case, if you're a clinical researcher, there are some granting agencies where you don't have to transfer your funds through UBC, and therefore you lose a whole lot less money. So this is what I recently discovered with, we got a Royal College grant for about $100,000, not a huge amount when you compare to people who are in basic science research, but for clinical researchers, that's a decent chunk of money. And we discovered that if we route it directly through our own corporations as clinicians, then UBC doesn't take about a 15% chunk of the money. So if any clinical researchers out there are getting those sort of smaller, medium research funds, consider that and feel free to reach out, because when you're talking about $100,000, 15% of that is not chump change.
Or question, how do you maximize the impact? How do you make sure you maximize the You were talking earlier, you're telling me about how you engage training, lab and so on, but Shahrzad. Tell us about the importance of making sure that it has impact over there and how you do.
Yeah, so I think I'm a little bit niche, and I hope this does apply to some people in the audience in some way, but the way we are analyzing impact is by the impact of our trainees. So essentially we have general practice doctors who are going through an 18-month curriculum to become surgeons, which is different from the 7 to 15-year process that we go through here in Canada. So really what we want to assess is whether the care that they are providing after 18 months in this program is equal to the care that would be provided by fully trained surgeons in their context. So we're not comparing them to surgeons here, but them to surgeons in their own context. So we look at patient outcomes, we look at volume of surgeries, we look at complexity of surgeries, and that's where it really helps to have an organization like MSF that we partner with, because we have robust data from the centers in which they work. So we want to prove that it's not only just equivalent to fully trained surgeons in their countries, but in many ways better. And for those of you who are interested in this topic of task shifting or task sharing, there's actually robust data out there that shows that surgical task shifting can be just as efficacious and also safe as compared to training surgeons the traditional route. So that's how we assess impact.
As Pascal pointed out, so for us really internally, the opportunities for trainees to interact not only within the community here, but in the global community and be exposed to, different viewpoints, different settings, having an appreciation for those. It's not really easy to count, but I think that's really tremendous impact. And then for the people that we work with in these various countries, we're still at the very early stages of publishing because this is a sort of a long-term endeavor. But I think on all the publications that we have done so far, we always make sure that there is an investigator, at least one or two, from the places that we work with, part of the publication. And even earlier has if these folks want to have the data first, so that they can build their own capacity as well.
Sure. I'm Hannah Ruth Engelbrecht. I'm a PhD student in Mike's lab, and I, as you mentioned, work on several of these global cohorts, and I am from South Africa, so I came to Canada with a different perspective. Thank you all for your lovely perspectives and interesting introductions to your work. One of the things I was curious about was when you are working with either different country centers or even within country, different partner organizations, how do you go about making sure that everyone is on the same page? Because we deal with that on a lab-based front as well, but we get to pull rank sometimes and say that we're the epigenetic experts. So if we've been kind of contracted to do the epigenetic component, we do generally know more in a lot of ways than our collaborators. And so we can motivate our own opinions. When it comes to something that has to be collaborative, you're relying on partners doing the training. How do you get everyone on the same page? Thank you.
It's very hard. So our most recent expansion of our training program is to the Central African Republic. And hopefully this will land with a non-clinical audience. I think it will, but we were having discussions with the Minister of Health of the Central African Republic about implementing the training program. And the Minister of Health said, yes, this is all well and good, but I really think we should be thinking about doing robotic surgery. And I mean, they are 50 to 100 years away from doing robotic surgery. And that's not an exaggeration. I mean, we're really talking about doing very basic surgery. So when you have that kind of disconnect, but he is the Minister of Health of that country, he holds all of the power with respect to healthcare expenditure. You have to tread very carefully. So there's a lot of massaging of egos. Luckily, as surgeons, we're used to that. We have to do that all through our training, but also recognizing, of course, that we each have strengths and experience and knowledge to bring to the table, and somehow managing to ensure that all of those strengths are acknowledged, while also acknowledging that some expertise, as you said, may trump other expertise. So our expertise is in curricular development and sound medical education principles, and his expertise is in his own country and the needs of his own country, and somehow we can meet in the middle. I'm sure you have experience to add.
Yeah, very similar answer. Yes, it is very, very challenging. And yes, it could be discouraging sometimes too. Just starting from just scheduling meetings in different parts of the world, just a very basic thing, like when you work in like 7 different time zones or whatever, right? How do you schedule a meeting? I've ended up doing meetings at 5 a.m., 5:30 a.m., or 10 p.m. at night. So just simple things like that, and then you talk about different perspectives, different strengths, different people bring in. It is definitely, I should have put it on my slide actually. But again, I think what you're saying makes sense, and that's what has been my experience too. You have to maybe just find people and their strengths if you can, and then just tap onto their strengths, and you have to be very strategic, which is something I'm still learning to be. I'm not very good at that. But you have to be strategic. You have to think in bigger picture. What can each person bring in to the table? And then hopefully everyone else agrees with it as well. And there will be disagreements, but I think open communication starting from the beginning, something I think could be helpful.
Hi, thank you again so much for the panel discussion today. My name is Emily and I'm a postdoctoral fellow at Simon Fraser University and also jointly affiliated with McMaster University in Ontario. So today, I guess I wanted to follow up on the question that was just asked a little bit in terms of building these partnerships from the beginning, right? Because we just talked a little bit about the politics and that relationships, that strategic approach. And so with research being a very extractive process, how do you go about like meeting those needs of the community? Or you mentioned during your presentation how you can learn a lot from LMICs as well and the different communities. And so is there anything that you have learned that you were able to bring back to Canada? And how do you go about navigating all of those cultural differences and making sure it's not just about what you want, but what they might be needing as well?
I think in terms of finding those opportunities, and I think I've been really, really fortunate with that. My mentors, and one of my mentors was in fact from McMaster, who is an expert in quality of life research and building patient-reported outcome measures. So I spent a lot of time with her, and through her connections, I was able to meet other experts in the field. So I think that's one way. Go to different conferences in your area, and don't hesitate to do those mentor-mentee sessions to expand your connections and find mentors in your area. In terms of learning, specifically from those low and middle income countries, I think specifically in terms of like the clinical field, I mean, I see one of the centers I was showing in India, they see like 300 patients in one orthopedic OPD. And I think in our orthopedic clinic in one day, they see like 50 to 60 patients or something. So I'm sure, so that's not a lesson I would say for me, because I'm not a clinician, but I think that's still some of the things maybe the clinical systems could see, like how do they manage to see 300 patients in one day versus, and from those 300 patients, imagine how much data you could get as opposed to like we have 50 patients here. So that's where I think there could be certain lessons you could learn.
I think the biggest lesson I would impart is to fight against the tokenism of acknowledging research contributions, which I think is really prevalent nowadays when you engage in research with a low middle income country partner, to just make sure that you throw a few of them on the paper. And I really, really dislike that. I think it's even more insulting than not, honestly. So if you're going to be extractive, at least be upfront and honest about the fact that you're being extractive, and don't just throw people's name on just because you're trying to say that you weren't extractive. So what we really try to do in our global surgery lab is make sure we have meaningful partnerships. And so if we have a student or a resident or a postdoctoral research fellow or a clinician involved with a research project, try to find out from them what they want to learn from that research collaboration. So recently we published a paper looking at a qualitative paper looking at experiences of clinicians in Liberia. And our Liberian partner said he really wanted to learn how to code qualitative interviews. And so that's what we focused on. He really didn't pay much of a part in writing the protocol or in writing the final paper. He obviously gave a lot of his lived experiences that made that process richer. But what he learned and took from it was sitting down one-on-one with our medical student who had a lot of qualitative experience and learning how to code interviews, so he could at least take that skill away. So I think trying to fight against that tokenism of acknowledging partnership and trying to actually have a deeper partnership that's meaningful in some way for the person on the extractive end.
Yeah, no, I mean, for us, it's a little bit more challenging because we're one step further removed, and we're working largely with population cohorts. So we kind of rely on our partners in the country of origin to have done things properly, which, you know, and we do have conversations. I think for us, it's slightly different also because we're, you know, there's nowhere these folks in these countries can do what we can do. And so, you know, our way of giving back is authorships. but in a way that people are actually engaged. And importantly, the training, as challenging as it's. So, for example, we're supposed to, we're having this project. We just ran the epigenetic arrays with these folks in Karachi, Aga Khan. The guy, everything is said, welcome Leap has agreed to finance. Coming back to the earlier question. Well, with the changes in Canadian student admissions, he is stuck. He can't come to Canada. We have other places, like we were talking about, the scholar from Cape Town who was here twice, I think, right? And she's now an assistant professor there, and she is now building that, at least the analytical capacity there. So, it's challenging. As Hannah Ruth and Hannah from my lab, we challenge ourselves in lab meetings. Like, for example, last Friday we had a lab meeting, and I was challenging, how do we know that these people that we're talking about actually like what we do? So, and I don't know whether they do or not, but it's at least worth or important, I think, to think about it. Yes.
We're at time, but okay, maybe 2 quick questions, then we close it. Do you want to introduce quickly? One word?
My name is Sure. Hi, my name is. Got it. Okay, it's well lit now. Sorry about that. So my name is Mohsen. I work for First Nations Health Authority, which provides Health Canada functions for BC Aboriginals to help with the reconciliation process, help them be in charge of their own healthcare. My question is because I was recently actually traveling to Karachi, as mentioned, and one thing I noticed is there's a lot of privatization of everything to do with healthcare, right? On every level, like even when it comes to like the public infrastructure, certain things that we would consider, the public healthcare system should be supplying these kind of things, like all that kind of stuff is private. So I was just wondering if you guys encountered that in your travels, either in Pakistan or any other country in the developing world, and how to navigate those kind of spaces where, a lot of the impoverished don't necessarily have access to public health. Or I mean, even in Canada, we're more fortunate than the US on that front, right? So is that something that you guys have encountered?
I think I work in areas that are too poor to have privatization of healthcare. So it doesn't apply so much to me as I think it does to those who work in middle income countries.
I haven't encountered too much in the type of work I do there, but one thing I did see recently is because now there are like the private hospitals in India and few other low and middle income countries, it has become a little bit easier to do research because some of those don't have those stringent guidelines that comes with a university or a knowledge institute. So they have their own small governing bodies, which sometimes made things easier in my experience in few encounters, because they don't have to go to a big body that has months and months of waiting period for approval. It worked out in our favor in that way, that they still had a small governing body, which was just for 1 or 2 hospitals. They quickly reviewed things, they quickly approved things, and we were able to get the data or get our work done there, as opposed to one of the centers that I showed in my slide. It took almost a year because it is one of the leading tertiary care hospitals. There were a lot of approvals, a lot of pushbacks until we finally got the approval. So that's my experience so far, which has been in my favor.
Just very briefly, so the last time I was in Karachi was 12 years ago, and there was, and even now, I think all our studies, and Ruth, correct me if I'm wrong, are actually exclusively done through the Aga Khan University Health Network. So I'm not sure to the extent that they would tap into the private sector.
So Aga Khan is one of the exceptions where like the impoverished can actually, like poor class actually do have access to adequate healthcare resources. It's, I guess, the nonprofit nature of it, plus quality healthcare,
Right, that was my
So
impression, yeah.
that's actually the demographic, because otherwise, usually, like she was saying, right? Like, yeah, the private hospitals are better because everything's more efficient, right? So things can happen quicker. But there's a specific class of people that can actually afford that healthcare, right?
Sure, and our work is very much in the social determinants of health, so we'd like to span the spectrum and not just skim off the 1% that probably can use that. That said, actually, we had a company from India in my office last week who was trying to sort of explore opportunities for private sort of epigenetic testing in India. And they were talking exactly about what you're talking about, how there's a lot of growth and opportunity for private healthcare delivery.
I think we're at the hour, but before, I think we could probably stay around for a little bit. But before I get to your question, there's a question online to Shahrzad, I think, about the development of your training program. And I'll let you say a few words, but Shahrzad sent a link to a YouTube video that has all the information about the program, which we're happy to, Stephanie, you're gonna send to that person. But do you want to say a few words, maybe? It's a big question, but try to condense it in a few sentences.
What was the gist of the question?
What process you use to develop?
Oh,
So essentially, we took content experts. So we're trying to, as I said, train general practice physicians in the breadth of surgery. So we have 10 modules and have surgical subspecialists across those 10 modules. We did a little bit of crowdsourcing. So we had students and residents do some of the writing, and then the content experts clarified those modules. We got a grant through UBC to put this all online on the EduX platform. Some of you may have used in your education, and have been really lucky along the way to have people drop in at the right time. So we had a education PhD who became our lab coordinator, who really made sure that the principles of adult education were adhered to in the design of our curriculum. And then more recently, we've had a undergrad or a medical student with a lot of she was a software engineer before she went to medical school, drop in to our lives to help us really make sure that it's all a well-oiled machine on the new platform. The other thing that we've used is, some of you who are in medical education may be aware, competency-based medical education, CBME. So the way that we assess the development of skills, both technical and non-technical, for our trainees is through this thing called EPA. So it's all in the YouTube video. And if this person would like to discuss more with me, so I don't bore those who are not in medical education, I'm more than happy to chat ad nauseum about how we developed this.
Thank you, doctors. I'm Lauren. I work for European pharmaceutical companies as regulatory affair, and now I'm an individual member of Life Science BC. So my question is that children are often underrepresented in clinical trial due to ethical and regulatory challenge. How can we access innovative in global health are adequately accessible to pediatric population? Thank you.
As such, so I'm not going to be able to answer very well, but I think outcomes would be.
Can you repeat your question one more time? I just got the last bit of it.
Yeah, my question is that children are often underrepresented in clinical trial due to ethical and regulatory challenge. So how can we ensure the innovation in global health are equitably accessed to pediatric population?
I also don't do a lot of clinical trials, and all of my work has been in pediatrics. So I think it's, if your research question is focused around pediatrics, around children, you have to really hone down your rationale to represent that patient population, right? If you don't tap into those patient population, because often, yes, we think that children cannot, such as in my area, like quality of life research, they say, oh, kids cannot they cannot tell their story, they don't know. But then now there has been research that kids almost starting from the age of 5 years, they can talk about their health. So I think you really have to find literature, even though there might be less, that can strengthen their argument that kids, they can talk about their feelings, they can talk about how their condition impacts them. And I think there's a lot of qualitative work, which I found in my area. And we started, and I'm not like the first person who's doing it, right? So I'm sure in those areas, you have to find research, you have to strengthen your argument that kids can actually be reliable for providing information for your research and for your clinical purposes.
I would imagine.
Also, I mean, we don't do clinical trials either, but at least two of our studies actually were randomized controlled trials in both Bangladesh and Ghana on early life, maternal and early life nutrients, micronutrients and such. So that is, I think, a huge space in the global health domain, and certainly something that we have been looking at, but I wouldn't call that a clinical trial because it's done in community settings.
I would imagine it will be really important to involve the user of that research in the community from the very beginning in designing your question, getting the funding and so on. And that's one way to make sure that it's transferred back equitably to people that need it most.
It's called co-creation. I recently served on an NFRF and an Moderator. That's all the rage of co-creation.
All these fancy words.
Sorry, I wanted to add one more thing. Again, it's not something new that I'm just talking about, like patient partners and having patients and their families involved when you are maybe writing your proposal or writing it. So having that backup from the patient group as a patient partner or family partners could also strengthen your proposal or your funding, whatever, or your proposal for clinical trials. Again, just talking about the same thing that Pascal is saying. And that model has worked for us in a lot of our like research proposals to have a patient partner.
So thank you. Before we lose too many people on the online, I wanted to thank our 3 panelists for coming. It was certainly, yeah, you can go ahead. It certainly wasn't, it's not an easy task to encapsulate years of experience in your fields in a 6-minute presentation, but I hope it was informative for those of you who are involved or think about getting involved. And maybe I think we have the room for a little bit of time. We could just stay here, and if you have some time to stay and just informally get a drink, some fruits and cookies, and we can continue chatting. Thank you for coming. Bye.